the slides that we've got. So just give me a second and I'll bring those up. I'm hoping that everybody can see those nicely. Have we got a thumbs up? Okay, so everybody can see. So yeah, just formally to say hello and welcome to everybody that's able to join us this afternoon. It's a fantastic opportunity for us in terms of the launch of this event that we've got today, and I'm absolutely delighted with the people that are able to join us, and I'm hoping it's going to be really useful to you and that we'll all learn something. So just to say, this event will be recorded. We will be sharing not only the copy of the video, but also the slides and a number of other bits and pieces that hopefully are helpful in terms of supporting information after this event. So please do look out for an email in your inbox once we're finished. And of course, feel free to follow up with any of us as and when, if you'd like to do so. In the meantime, just to let you know, in terms of the agenda for today, again, hopefully you've had sight of this, but I'll start off with a brief welcome. We're then going to be joined by Dr. Yasir Abbasi, who will be talking us through actually what the current problem and issue is at the moment in the UK. So a really good overview from him, and delighted that he's able to join us this afternoon. We're then going to hear about our ReWire service from Graham Dixon, who established ReWire a number of years ago. So that'll be a really good session from Graham. And then we're going to finish up with talking specifically about our new ReWire skills and assessment service, and Kieran will do that for us, and what's available in terms of the support that we can provide. We'll have a final Q&A session, but we will be taking questions as we go. So after each speaker has presented, there's an opportunity to ask you questions that you might have. And I'd ask that you do that through the Q&A facility. If you look at the bottom of your screen, you should see a Q&A option. So please do type in any questions that you've got, and we'll pick those up as we go. But as I say, there's a Q&A session at the very end to pick up anything extra. But that's our agenda for this afternoon. We've got up to an hour and a half, and we'll just see how we go in terms of timing. But as I say, if you want to pick up with any of us beyond this session, then you're very welcome. So just to introduce myself very briefly, I'm Helen Gibson. I'm Agencia's Managing Director, and obviously we'll say just a small amount about what Agencia is doing in a moment. But those are my contact details, and just so you know who you're talking to. Agencia have been set up for 23 years, and everything that we're doing is around making change happen. And it's not just making any kind of change happen, as M&S might say, but we're making change happen that is change that will improve the quality of life for people. So we're wanting to do things that are actually going to make life better for the people that we're working with. So everything that we're doing, and it's quite a broad range of things, which I'll just mention, is designed to help make things better for people. So we've been going almost 23 years, over 450 contracts that we've delivered, extremely high rates of client satisfaction, which is great, and delivering not only in the UK, but across the world. And to date, we've worked in just over 20 countries. So that just gives you a flavour of where we're coming from. And a whole wide range of clients, both in this country and internationally. Again, it just gives you a flavour of the nature of the people that are coming to Agencia for the support that we're providing. In terms of ReWire, and Graham will speak specifically about this shortly, it's something that we set up as part of a whole range of work that we're doing around substance misuse. And having got into that work, recognised that there was a real problem in terms of painkillers, and as a result of that, thought, what is it that we can do to actually help to address that issue that we've uncovered in our wider substance misuse work? And as a result of that, designed a full service to be able to treat and help people that were at risk or had in fact actually got addicted to painkillers. So Graham will talk about that shortly, but just to say, ReWire in a nutshell is a whole suite of support, from the full service provision that is actually providing treatment to people, through to the sorts of things that we're talking about specifically today, that includes the hands-on assessment service and the skills development in terms of specific training that's on offer to be able to support people in dealing with this. So that just gives you a very brief flavour of actually what Agencia is doing in terms of our work in health and social care, justice, police and security, but also how ReWire has actually come into being and the focus obviously of our event today. So without further ado, I'll hand on to Dr. Yasir Abbasi, who, as I say, we're absolutely delighted to be able to join us today. And he'll talk us through actually what is the current situation in the UK with this at the moment. So good afternoon, Yasir.
Good afternoon, Helen. Good to be here.
Thank you.
Thank you very much. Thank you very much, Helen, for that introduction. Very kind of you. Those of you who've not met me yet, my name is Yasir Abbasi. I'm a consultant psychiatrist in addiction, and I'm currently the head of addiction service for an organization called Maudsley Health, which is based in the UAE, but has links within the UK. Prior to that, I was the clinical director for the addiction service at Merseycare NHS Trust, which is a mental health trust in Liverpool and surrounding areas. So it's a very interesting topic. I've had an interest in this area for almost 8 years now. When I first became a consultant in addiction in 2011, and that journey started in Leeds, very quickly did we identify that this particular area is not that well looked into, and the service developments, there's quite a dire need for service development in this area. And I set up at that time a very small pilot clinic, the first of its kind within the NHS in 2011, which only truly dealt with what we call prescribed addiction, which dealt with benzodiazepines as well as painkillers. This presentation is mainly focusing on opioid painkillers, but there are other issues associated with pregabalin and gabapentin nowadays that we're seeing. Lots of people after my presentation have come up to me and said, oh, what about paracetamol and ibuprofen? And I've always said, well, ibuprofen and paracetamol do not have the chemical components to cause or to lead up to addiction. But sometimes when they're mixed up with the opioids, can lead up to quite reasonable amount of substantial damage. But my journey with Graham started on a stormy, snowy night in Manchester almost 5 years ago, where we because of my interest, we kind of looked into this, and I had arranged a talk. The attendance was not as we expected because it snowed quite heavily that night, but Graham made it. And since then, as I say, the rest is history. We started discussing, talking, and we've collaborated ever since in a variety of ways. And then naturally the link with Graham and Agencia continued from then on. But it's an ever-growing problem, people being addicted to painkiller. It's ever so confusing because painkillers are a legitimate form of prescription. And also the fact that it is required to deal with legitimate and really complex physical health problems as well. How do you draw the line? Where do you draw the line? How do you treat it? How do you address it? What do you do? It's a complex problem. I don't profess to have all the answers, neither would I be able to provide you with all the answers today, but it's a very quick 20-minute overview. So if you go to the next slide, you will see my affiliations. As I said, I'm currently working at Maudsley Health. I'm also a clinical associate professor with Mohammed bin Rashid University over here in Dubai. I am also a founding trustee of a charity I set up with a lady who had developed painkiller addiction and then recovered. Her name is Catherine Kemp. We set up a charity called Painkiller Addiction Information Network, or PAIN for short. And we raise awareness around painkiller addiction for that all across the UK and internationally. So as we go to the next slide, my declaration of interest for previous presentations or work I've done, and none of this has been in the past 12 months. It's been more than 12 months ago. So go on to the next slide. I thought I'll start off with this. It's a very interesting news item I saw. And again, this was prepared for the presentation or the work I was doing in 2015. And this is a GP who was attacked and throttled in his little surgery in Swansea because he refused to prescribe painkillers to a patient. And this is not to kind of dramatize of how disturbing the problem is. The problem is there, but this is to show how difficult and challenging it can become, both for the clinician and for the patient. And I naturally have empathy for the doctor who's standing there with a crib bandage on his hand, but also for the patient. So if you see the next slide, this patient in the court is suggesting that he was telling the doctor that he's going to fight for his medication if he refused his demands for a painkiller prescription. And the first question that popped to my mind was, what led this individual to get to this point? I'm pretty sure this individual would have been a reasonably functioning individual. And when I read more about him, the person had not had any drug addiction in the past whatsoever. And neither did he have it now. It was mainly around painkiller addiction. So what led to someone trying to hold their doctor's neck and squeezing it and asking for something really, really dramatic and drastic? But as you see in the next slide, there's a severe lack of service. And this was published after Public Health England did a review of painkiller addiction, or prescribed drug dependence, they called it. And they looked at different things. And they reported there was a severe lack of services, which was picked up by The Guardian. So Guardian then took views from various clinicians. They took my view as well. And in the next slide, you'll see my view, which kind of highlighted how I think it's a hidden epidemic. How a lot of these people would be invisible in primary care, not picked up because they don't come forth, they don't recognize it as a problem themselves, neither do the clinicians, not in a sinister way, but because of lack of awareness, lack of understanding, or because of sheer frustration, because there's not much else that can be offered. Unfortunately, a patient comes to a doctor and they have a problem, and you're the person who's trying to solve that problem. The easiest solution is you have a pen, or well, you have a computer, and you can print out a script. And you need more supportive mechanisms in place to avoid doing that. And with time, these supportive mechanisms are being taken away more and more. This talks about two services, but it didn't mention Agencia's ReWire service in this article. So I think they've missed the ReWire service. And I would ask Helen to get in touch with Guardian to make sure they are aware of this. So if you go on to the next slide.
Yeah.
Yep.
I'll make a note of that.
Definitely make a note. So as we go along, we see if this was a live session, I would ask people to guess what they're trying to advertise in Mother's Little Helper. And they used to advertise Valium tablets, diazepam. In the society at that time when they lived, they thought it would help the mothers who'd spend a hectic day preparing the turkey and looking after the house at the end of the day to relax. A bit of one tablet of Valium would relax them out. So our understanding of diazepam versus diazepine was different at that time. So if you go along the next slide, you'll see how we were advertising heroin. So glycoheroin was advertised as a cough syrup. And the next slide also suggests that heroin again was advertised as a cough syrup. So the point we're trying to make over here is the fact that an understanding, and again, there's no sinister element to it, but the understanding of medication as it is, it might change over the period of years. So right now we feel that the painkillers that we use or the pregabalin that we use is absolutely essential. But as we understand the medication better, we understand the overall effects of what we're prescribing and might become more conservative how we use it. And this was an example of a patient who was using almost 64 tablets and trying to extract codeine from cocodamol in a way which wasn't really scientifically approved. But they're putting themselves at such danger that taking 64 tablets of cocodamol, which includes paracetamol as well, and putting the liver at risk. So if you go on to the next slide, this was just the painkiller charity that we are at, and Catherine Kemp is a former opioid pain addict who's talked quite a lot about it. So go on to the next slide. We will see a number of papers we've published around how prescription and how our prescription is done, how people are prescribed quite a lot of medication even when they're addicted to other substances. So someone using a lot of alcohol feeling depressed would be very easily given an antidepressant, even though the real establishment of the depressive disorder has not been there because the patient has been drinking alcohol quite regularly. If you go on to the next slide again, we will see another paper that was published around the pathway of painkiller dependence. So opioid analgesic dependence, let's move forward with the slides and further again, is something that needs to be done together. Brilliant, thank you. And it's not one person's responsibility, neither is it one individual's responsibility. It is such a holistic problem that we need multiple specialties to come in together to properly and holistically treat it. So if you have pain, you need to treat it really, but if you get addicted to the painkillers that you prescribe, then you need a variety of people, including pain specialists working together, trying to help you out. And I think the ReWire service is something that goes into the primary care, which shows good collaborative working, which Graham would explain in more details in his slides. So next slide would show how it compares to other problems. So if you look at asthma and diabetes, and then compare that to opioid analgesic dependence, OADs, opioid analgesic dependence, you'll see how the relapse rate is equivalent to asthma and diabetes, which, again, the bottom line from here to take is that if you have an opioid disorder or an opioid analgesic dependence, it is equivalent to a chronic illness such as asthma. It's relapsing and remitting. So that means that if you try and treat them, do not think that you can wave a magic wand, withhold the tablets, and suddenly, boom, they're recovered. It is a relapsing remitting illness, and it's a chronic condition, so you have to constantly be aware of that. We go on to the next slide. We would see how use of opioids can also lead to some neuroadaptation, some structural changes within the brain. The uptake of opioids and the sensitivity to opioids becomes more intense. And the brain becomes more sensitive to opioids. So people who are using chronic opioids for a long period of time then might be responding in a different way to opioids. So once the opioids have been stopped, for example, and then 3 years down the line, they have a surgery and opioids are reintroduced, their brain would fire up again, leading them to start craving more opioids. So hence, everybody needs to be aware of the past history of opioid addiction and make sure they're dealt in such a way that is inclusive of their problems that they're presented with. Next slide. The scale of the problem. So are we just kind of banging on about something which we don't know much about? The data is still out there for the jury to just suggest and determine, but you can see globally it's becoming more and more of a problem. The US has quite a high number of opioid analgesic use, and opioid analgesics were involved in 43% of all drug overdose deaths in the US. Canadians are also the second largest per capita consumers. It's increasing in Brazil. In Australia, it's becoming quite a big problem, non-medical use of pharmaceutical opioids. But this is outside the UK, and we're nowhere near what what is happening in the US and even Canada, but mainly the US, because their healthcare system is very different to our healthcare system. And our healthcare system, in a way, may not be preventative, but definitely is a healthcare system which is able to contain the problem more easily as compared to the US healthcare system. But if you look within Europe, in the next slide, you will see the use of, this is not the European data, this is outside Europe again. The next slide is Europe, but in this data, you can see the prescription opioids are being used more and the heroin production is going less and less. And the per capita use, again, very clearly highlighted as the previous slides. In Europe, it's quite high, including the UK and the US. So the per capita use is more than 100 milligrams per head. For some countries, we don't have the data, hence the white. From other countries, you might not have the full data. But UK seems to be definitely in the European countries which have higher consumption of opioids. So if you go on to the next slide, and the next slide, you would want to know, why would we want to treat it? If someone's using painkillers, well, let's just go on and let them use it. What is the problem? But if you use lots of opioid, it does cause intoxication, it does affect your cognitive function, it does affect your level of alertness, and it affects a number of functioning. It can also have long-term effects. It can have long-term effects on your endocrine system. Opioids, any types of opioids, including heroin, but any type of opioids, including prescribed, can have effects on your sexual hormones, particularly testosterone, and can reduce them. It can cause hyperalgesia, which is a condition where you are more sensitive to pain. It can reduce your immunity, affect your sleep, and cause an instability in your mood. And it can affect your employment because you're sleeping more, you're drowsy more, or it's affecting your relationship, and you're going through a number of different traumas because of you using constant painkillers. But then you are in pain as well. So you need to have the right balance. You can't constantly be in pain. You need to have the right balance. But if the problem is impacting on your physical, psychological, social health, you need help. If you're using opioid painkillers and it's affecting you in all these domains, you need immediate help. So if you go on to the next slide, we will see how persistent pain affects a variety of areas in our body and our brain and our mind. And if you go on to the next slide, it will show how it overlaps with addiction as well. So persistent pain is not good, neither is addiction. And that is the strong message I want you to take away from this, really. Pain isn't good. I'm not suggesting, and we're not in any way suggesting that people should be in pain. But addiction isn't good either. And hence we need to have a right balance. If you go on to the next slide, you will see how they're closely linked. You treat one, and you treat the other, and you treat all of them together, and it impacts all of them and improves all of them together. Next slide, please. So who is prone to develop OAD? Again, we don't have a clear-cut answer, but we have some idea and some risk factors. So patients with prescribed opioid analgesics over a long period of time, particularly those who are prescribed it for non-cancer pain. For cancer pain, you can continue to have treatment for as long as it's required. For non-cancer pain, then you're at high risk. You have a family history of dependence, any kind of addiction, including alcohol, would cause a genetic predisposition. Personal psychological profile, if you're someone who's always anxious, if you're someone who becomes dependent on things very quickly, including other human beings, and those who have comorbid psychological problems, they have higher risk of becoming dependent. That doesn't mean that if you have any of these risk factors, you immediately become dependent. You are at risk. Hence, you need to be more aware, and the prescriber needs to be more aware. So if you go on to the next slide, we've kind of divided patients in 4 categories, and they sometimes overlap. So the patients with ongoing pain, and they develop addiction. Then the patients with resolved pain, but they continue to use their painkillers. And then they make up stories with the clinician saying they're still in pain. Then there are patients with poorly managed pain. Really, the pain is not properly managed. So it's not just ongoing, but it's not really controlled very well. It's constant pain throughout, and they then start seeking other avenues other than the clinician. And then there are those who would use it recreationally. So if you go on to the next slide, it kind of shows you a continuum of non-medical users and pain patients. If you press the slide again, you will see how people can move between self-treaters for pain and adherence to addicted patients. So a lot of teenagers in the US, for example, started using it when they got medication from their family or friends. So be aware when your teenager is visiting your nana who's taking tramadol for her hip pain, that your teenager is not then comes back high on her tramadol. And this is without anyone's knowledge, not that the nana is trying to make them an addict. So just to be aware. And again, for those with chronic non-cancer pain, the addiction rate can vary from really 0% to 50%. And that is why it becomes more difficult to predict, because you can see the variety or the range is quite wide. So if you go on to the next slide, we can see the continuum behavior moves on to the pathway of dependence. And if you click the slides again, you can see it starts with prescription opioids. With period of time you want to continue because the pain is not that well controlled, and then you lose tolerance and you become dependent. And then when you become dependent, then you start looking at cheaper alternatives and become sometimes a gateway to hardcore drugs. You're trying to obtain analgesics from non-secure manners like dealers or websites and online, which is also quite, well, not that well controlled or contained. And it was something that I was working on when in the UK. It was something that we were all very concerned about. And then people become addicted. So the next slide, and we can very quickly go through this slide, Helen, if you don't mind. So patients present with chronic pain, opioid dependence, chronic use, hyperalgesia, and then dependence if they can't do anything else. So next slide. So over here, can we stop here? So it's very important that you kind of look at where you need to really stop and consider. So when you're prescribing opioid painkillers, it's at that point in time you stop and say, listen, is there something else can we do for them? Is there something else that we can prescribe in terms of prescription? Can we provide them with some sort of alternative ways of controlling their pain? Cognitive behavioral therapy has a lot of evidence in chronic pain. So instead of prescribing opioids, you kind of start thinking that. So if you press the slide again, you'll see when you want to increase the dose, you think, well, do we really want to increase it? Do we want to look at other avenues? And once they're dependent, it's at that point in time you start thinking, what do we do? Should we start looking at detoxification because it's not working for them? And that is where you'll start looking into other services, tertiary care services. So when you feel you're giving them higher doses or where you feel they're dependent, that is where services like agency will come in play. Carry on. So what I would always suggest and I always focus on is the possible risk factors or the possible signs that you can see. So Savage describes them as the 4 C's. So if you press the slide, and you'll see these 4 C's. Adverse consequences. You see the patient's quite intoxicated or irritable, or there's increased sleep disturbances, or the pain complaint is constantly increasing every time they come and see you. The next C is impaired control. They come on for repeated prescriptions. And there's so many times that the dog has eaten the painkillers, or there's so many times that they've forgotten their prescription on a bus, or there's so many times that they threw it in the bin. And it kind of should raise up red flags. The next C is about them becoming, craving. They are focusing on specific type of painkillers, and they are focusing on specific amount of painkillers. They are dismissive of any kind of treatment that can be offered to them apart from the opiate painkillers. So these C's are very important. So adverse consequences, that's 1 C. Impaired control or compulsive use, those are 2 C's, so that's 3. And then the 4th is craving, and they're constantly preoccupied. And particularly when you call them for a full review, they miss that appointment because something dramatic happened. And I guess you'd keep a tab on how many times they're trying to kill off their elderly parents. And then your relatives can only die so many times. And I've had someone who came up to me in my addiction service whose grandmother had died 5 times. And we had to actually stop him there and said, that's enough. So if you go on to the next slide, there are some validated tools which you can use to screen, to assess risk. These are not diagnostic tools. Again, they do not diagnose you with an opioid analgesic addiction, but they screen you with having problems. So say there's a single question screening test which simply says, how many times in the past year have you used an illegal drug or used prescription medication for non-medical reasons? And for me, sometimes I quickly ask them this: how many times have you used a prescription opioid medication for non-medical reason? Because you were anxious. Even if they say once, that doesn't mean I'm going to stop the medication, but that just simply means I need to keep a very close eye. And then we need to discuss it in a very open manner. But the ORAT, or the ORT, opioid risk assessment tool, is a good way of identifying from case records what high and low risk patients are, which doesn't mean, again, that you simply go and cut off the painkillers, but simply means that you, again, review the case more closely. So if you go on to the next slide, it will look at the domains of addiction, how you need to treat it. So if someone's addicted, please do not cut off their prescription immediately. You need to make sure you're aware of all the other aspects that are at play and work with them to reduce it slowly. If you cut it off, you're creating more problems. They might most probably then start seeking more hardcore drugs from illegal avenues. So the next slide, please, would talk about treating. So there are, as I said, pharmacological treatment is either you start doing a proper detoxification, you can admit them and do a detoxification, or you could work with them and taper things off slowly and gradually. There's no fixed regime. I always encourage it to be very patient-centric. As long as the medication is going down, the duration of taper doesn't matter. As long as you're reducing. On occasions where things have been very difficult, we've held the dose at the dose that they're at rather than increasing it and then reduce it later on. You need to also work in an applied behavioral analytic type of way, ABA. So positively reinforce any gains and negatively reinforce any other aspects of trying to ask for more medication. Cognitive behavioral therapy has been used. So there was a GP in Bradford when I was working with a number of people in the UK called Frances Cole. She also wrote a book about it, and they looked at using cognitive behavioral therapy for chronic pain, which was very useful. And also using opioid substitute treatment like methadone and buprenorphine. Sometimes I've seen people using excessive amount of painkillers, tramadol, oxycodone prescribed, and they're buying cocodamol from the counter. And it was impossible to taper all that because there were 3 different medications. And it was very, very, very complex to do it all 3 of them together. So we just amalgamated everything into an opioid substitute like methadone. And when we put them on methadone, it was a shocker for them because they thought methadone was just for drug users. And when they were on it, they then only realized how drastic the condition was. And naturally, you encourage them to manage their pain and engage in activities which is feasible for them. So if you go on to the next slide, and we're very quickly coming on to the end of our...
And just to say, just another 5 minutes or so, you say 5 or 10 minutes.
Thank you very much.
Bit of a warning for you on the timing.
Thank you. We're almost there. So this was a paper published.
You've done well.
Okay, good. We're almost finishing. So this was a paper published in Heroin Addiction and Related Clinical Problems with other authors and myself. It's a very complex diagram, but it looked at what could be done if someone was diagnosed with opioid analgesic dependence. And a declaration of interest for this paper was there was some support from a pharmaceutical company called Indivior, who produces a medication called Suboxone, but we're not in any way or form propagating that a particular medication should be used or can be used. We're suggesting that the 3 options for opioid substitute treatment when it comes to opioid substitute treatment: Suboxone, buprenorphine only, known as Subutex, and methadone. And all 3 can be used and should be tried if whatever fits the patient profile. And one should, right at the beginning, see that the adjunctive therapy and support should be put in place before even considering any other type of other aspect. And there should be a full pain, psychological, physical, and well-being assessment before we embark on trying to help them recover. So next slide, please. There's a summary, and I think one by one as we can go along, please, Helen, and this would be the last one. So it can affect anyone, you, me, Graham, Helen, anyone can go through this. We can sit on this side and judge other people and say, well, why are you using it? But it can affect anyone. Painkillers are not evil. They are legitimate, very useful prescriptions used for very useful reasons. And it is very important to understand, very important for you to take this home. Long-term use of opioid is not addiction. There are some people with really serious chronic health problems, and they're using chronic opioids in a prescribed manner, in the way it was given, for some period of time, or for a long period of time, for years on end. And that does not mean they're addicted. Any aberrant use or use of painkillers outside the prescribing description is what we call addiction. So next point is there's a constant review of pain and prescription together. So the onus is on the patient as well as a clinician. Whoever you are, whether you're a nurse, a social worker, a healthcare assistant, a GP, a psychiatrist, an addiction psychiatrist, a pain specialist, and any doctor or even a receptionist. If you feel you've given this pain prescription quite regularly for quite a period of time, then you need to highlight it to someone to make sure it's reviewed. Next point is non-pharmacological, as you discussed, particularly evidence based around CBT for chronic pain. Next slide. And as we said, we can also screen for high-risk patient using one of the screening tools. Next slide, please. There are no properly commissioned opioid analgesic services, but some services do offer treatment. Public Health England commissioned a report on prescribed dependence, and Matt Hancock set up a committee under Public Health England. I was part of the expert reference group, which kept on meeting regularly until July 2019. And then they published a report later on about it. And I met with all the other professionals who were experts in this field, and we provided overview as to how this needs to be addressed. Next point. And again, treatment can be weaning, stopping, opiate substitute treatment, or even a detox directly. But please remember, do not suddenly stop the painkillers once you've identified addiction. Even if you've identified addiction, you need to work collaboratively to make sure you don't put the person at more risk of further deterioration. And I think that brings me to an end. If there's nothing else in the slide, thank you very much. And these are my contact details. I do tweet, so follow me on Twitter if you want to. If you have any questions, please email me. And you've got the charity website as well to find me. Thank you so much.
Okay, thanks, Yasir. That's extremely useful and very interesting. I'm just going to come out of the slide share for a moment and an opportunity for questions that might want to come through to you. I've had a very quick look at the chat, but I've just got one question, but it seems to only be half a question. So I'm hoping if the person is able to put the second part of the question, that'd be great.
I think I've seen the second half of the question.
Oh, there. Have you? Right. Oh, brilliant.
I think it's by Soraya. I think I know Soraya well. Hi, Soraya. I hope you're well. It's good to hear from you. Remember working with Soraya in the Northeast, where she was part of the addiction service over there. So it's very lovely for you to join us. So she's asking, we have a patient referred by the GP who is prescribed high dose opiates. The GP wants our service to help them withdraw from the medication, but the patient does not agree. We have stated that the patient and the GP need to agree a collaborative plan to reduce first, and we can support. Any advice for the GP for agreeing a collaborative plan? And again, a brilliant question. This is something that we were identifying in our tertiary care addiction service in Liverpool, even though we did not have a specific opioid analgesic service there, but we dealt with a number of these types of issues. The first thing we did was to emphasize that I wanted a review from the pain services as well, if there was one available. There was one available in Liverpool, and we worked very closely with them, and they worked quite responsibly with us. So we emphasized that we want a full pain holistic assessment. So for us to really establish where we are in terms of the organicity of the pain. And that also helped establish a rapport with the patient as well, in terms of us trying to understand really where they're coming from when it comes to pain. So that was the first step. And then we worked with a patient who then got an assessment from the pain specialist. The pain specialist has similar views as us, and then we took it back to the GP. And then we started working together. We then, it's always difficult because we're very busy nowadays and we don't have as many resources as we used to. But I went out of the way for that particular patient and said, I will sit down with the GP and do a 10-minute assessment with the GP, a joint consultation, where we both were together, and the patient then agreed based on the pain specialist review. But if you don't have a pain specialist review, I think it would be very good to identify again why in the first place the patient was prescribed this, and what led to the increase. So where is the patient coming from? Why is it that they still are experiencing, or they still think the pain medication is absolutely necessary for them, because they're disagreeing with that. And sometimes, Soraya, and I'm pretty sure, Soraya, you've seen this as well in your clinical practice, what I've seen over and over and over again, I would be confident enough to say 90% of the cases that I've dealt with in opioid and analgesic dependence, is a lot of patients misperceive their withdrawal as exacerbation of pain. So when the GP is reducing the painkiller, they start having body aches and they start having opiate withdrawal symptoms, and they think their pain is getting worse, and they start taking more and more. And just working and identifying this with the patient was enough for them to understand this. And at least 30% of my patients were happy with this explanation and worked to reduce this. So I guess working collaboratively with the GP is trying to do a joint assessment and see why was it established in the first place and how we need to move forward.
I've got another couple of questions you say that have just come through. One is, how do we recognize hyperalgesia? Is question
hyperalgesia. Okay, yes.
How would we recognize that?
Okay. So hyperalgesia is really increased sensitivity to pain, and the science behind it is that your opioid receptors are becoming, your pain receptors are becoming quite sensitive to pain, because they're constantly being, the opioid pathway is constantly being blocked. And the moment it gets any chance and it experiences any pain, there's a very intense reaction to it. One thing we did, and I'll give you a personal example, is an elderly patient in the late 60s, early 70s, I think, was using prescribed prescribed codeine at maximum dose, and they were buying cocodamol over the counter as well because the pain wasn't controlled. And we sit down, we discuss hyperalgesia with them. But we also discovered that this chap was very interested in gardening and would do garden quite a bit. And we discussed hyperalgesia, how the back pain would get worse, and he had arthritis. And we discussed how arthritis can be a chronic problem, and you might never be able to bring pain down to zero. So it's also managing the expectations and goals. So we worked with them and trying to explain how sensitive the pain receptors could be, and how about trying to reduce it, and also reducing the time that they spend on gardening. We help them use the mobile to set an alarm every 10 minutes. So for 10 minutes, they would garden, the alarm would go off, and they'll take a 5-10 minute rest, and then go back to gardening. And they automatically reduce the codeine or painkiller use from such regular every day to once or twice or 3 times weekly. They're still using it, but only 3 to 4 times weekly, that too within prescribed limits. But you, again, trying to go back to your question, is I would do a pain chart, pain diary with them. And I have done that with a number of people. It's not exceptionally pinpointy scientific, but it's helped me highlight that with a few patients. So I would say, tell me when you experienced pain, what happened and how intense it was. And they've highlighted, oh, I hit my hand on the door and the pain was on a scale of 0 to 10, it was 9. And then we reflected, how can hitting a hand on the door be 9? Did you fracture something? Was it swollen? Did you end up in hospital? Did you have an x-ray? And when an answer to that is all no, then I said, well, how can it be 9? Can you just, and then we again reflected back on hyperalgesia. So the pain diary did help identify some elements of hyperalgesia.
That's really good, Yasir. Thanks very much. And I've got one final question, and then I think we'll need to move on to our next speaker.
I thought.
So it's around, is brain articulation, can that be from benzos or from alcohol? So is brain articulation from benzos or alcohol?
Yes, okay.
I think that's our last question.
With opioids, we've discussed this. Okay, I'll be very quick in answering this. I won't take a long time. So the quick answer is, we're still doing brain imaging and still studying that. Even with the opioids, there is. With alcohol, the more you withdraw, the more withdrawal becomes more intense. So there's, again, kindling effect in the brain. And there are evidence that it does cause structural changes within the brain, without a doubt, with alcohol. But it's still establishing that as we're getting more and more better at imaging. And my hunch would be with benzos is the same. That would be my hunch, but I won't be able to give you a strong scientific answer immediately right now. But my hunch is yes.
Okay, well, thank you very much, Yasir. That's been extremely interesting. I've learned a lot, and I'm sure other people have as well. So thank you so much. We're going to move on to our next speaker, which is Graham. So I'll put the slide share back up. Are you leaving us now, Yasir? If so, I'll say bye-bye. Otherwise,
Thank you very much. I will leave in about 5 minutes, but it's good to be here. Thank you everyone for attending.
Well, thank you very much, and speak to you soon. Okay, so Graham, I think we're okay in terms of your slides now, so over to you.
Great. Well, firstly, thanks, Yasir. That was fascinating. And for those who could see, you probably saw me nodding away a lot. I won't forget that journey across to Leeds on that snowy night, and the journey back was even more exciting. But, we have worked together, and it has been a real pleasure. One of the reasons we set up the ReWire service was I went to the Royal College of General Practitioners Substance Misuse Conference. And there was a breakout room about opioid painkiller misuse, and the room was full, absolutely full. There was no space. People were round the back. And when the presenter gave his answers, the answers were, this is really complicated. We're not really sure what to do because of people obtaining drugs illicitly, buying over-the-counter medications, and it demonstrated, one, that there was a huge sort of groundswell of problems, and two, that the solutions weren't that easy. And it was really nice a few years later to go back to the conference, actually win an award for our paper on ReWire. So it's there are things that are happening, but this is not a simple area. So if we go on to what ReWire is and how we developed it, if we just go on to the next slide. So ReWire as a concept, this looks like a very finished article, this. We do all these things, but I can assure you a few years ago, it wasn't so much like this. And one of the things, again, Yasir mentioned people with asthma and diabetes. And when we initially set up the ReWire service, we got a lot of help from the diabetes nurses who said, we're really good at getting people who don't want to come through the door in. And they helped us structure our letters and our approaches. So this has been, from the very beginning, a collaborative approach. But how ReWire worked was we ran a tool called the ORAT, which is the Opioid Risk Assessment Tool, a software mechanism that runs across, for those who are interested, the SNOMED database, which has been redeveloped. It's replaced a lot of the read codes now, both nationally and internationally. And use that against a set of criteria. We call them inferences to identify people who had a past history of addiction, long-term addiction, change in doctors, etc. increasing repeat prescribing. So all those potential areas of concern were highlighted for the patients. So we ran it across the GP database. It was then assessed using an experienced pharmacist, and we tried to have a consistent view on it. So we then prioritized the patients and wrote to them, called them in for a review as appropriate. Behind the call-in, there was a psychosocial support, there was pharmacological support, we had some GPs who had a special interest. And so rather than simply saying, come in, we're really concerned about your painkiller use, we were able to present it as this is a positive step, we're inviting you in for review. 2, we had a structure in place so that the patients had more than just the 10-minute GP appointment, because in 10 minutes, you're simply not going to get to the bottom of this. As Yasser said, there's a tendency to to use the computer and re-sign the prescription. We discovered, as again Yasser mentioned, there's a lot of dogs with an incredibly high tolerance for opioids. But the majority of people, and this was the thing that really came through, the majority of people, because we reached out to them, they were concerned. They had a worry themselves. And therefore, when we actually called them in for the assessment and they had time to talk, we were able to get some very, very positive engagement. If we can go on to the next slide, please. So, over 8,000 patients, we came out with 200 patients who were at risk. And this is quite interesting because there was a previous study done in Gloucester, South Gloucester, which seemed to indicate about 40 to 60 patients per 1,000 would be at risk of opioid addiction. So the figures seem to map onto that. And the other thing I would stress is that this maps quite closely onto areas of deprivation. If you looked at the opioid misuse around UK, it maps very, very closely onto the areas of deprivation. And painkillers, as we know, have less effects on if you've got a low mood. They can be used for stress relief. So there's a whole basket of other issues lying beneath these simple facts. When we contacted the patients, a lot of them just said, well, actually, I haven't really thought about this too much. And they cancelled or changed their prescription. And that was pretty much straight away. Because we worked across a few GP practices, we were also able to learn. So at the first GPs, we simply phoned people in, as you would, sent out a letter, people were called in. And then we got some feedback from the receptionist saying they were having a problem or two. They were getting some quite sort of antsy telephone calls. So when we went on to the next practice, we actually trained the receptionist on how to relieve the concerns of patients when they were coming in for the appointment. And we tried to create an environment in which everybody was incredibly supportive of the patient. And when we set up the service, we found we were getting pharmacists asking for training about what we were doing, and we were able to, other GPs were referring patients in, and we had very little resistance. I mean, Yasser mentioned that the doctor who was throttled. We had one patient who was immensely empathic, but as a little bit of background, he was a cage fighter, bare fist fighter, who was using both painkillers and alcohol so he could get back in the ring more quickly, and that was how he earned his living. He was an interesting character, and eventually we did get him engaged, and with some family support, he entered proper opioid substitution therapy. But on the whole, the patients were very positive. I would also reinforce what Yasser said about many did not know the difference between pain and withdrawal. And simply by being able to introduce this, and again, because we were proactive, reaching out to them, we were able to hold those discussions and help them, effectively encourage them to be almost their own science experiment. We pointed them towards various support facilities like the pain network and the pain toolkit. So there was a lot of background support going on. If we can move on to the next one. So we had up to 6 structured psychosocial sessions. Pharmacies were available. We had online support networks. We also found that the patients, some of them actually joined a support group and started interacting that way. So we had a lot of what I would call virtuous circle activity going on. But the main reason for this was because in the first case, we identified the patients and reached out to them. rather than simply waiting. We had a very good multidisciplinary team to handle more complex patients, and we had some a transfer route for patients into the more who had ongoing pain into pain clinics, but also we could talk to the GPs, and we found that the doctors, because we were there and able to add support, felt much more confident in raising this issue. And it is not a simple issue to raise. Much of this was actually around teaching people how to have difficult conversations and reassuring health professionals that the reaction they expected, which was, I'm not having anything to do with this, I'm very, very resistant, wasn't the reaction that we were getting. We were actually finding that patients were engaged, interested and concerned. We were often able to involve family in the treatment journey, and many of the patients, again, didn't realise how concerned their families were, because they were so spaced out at home. But they weren't aware of it because obviously they were spaced out at home. So all those things worked to create a service which was very effective for the patients. If we could move on. Just click through this a little bit. Go back. Yeah. So as I say, we ran I prioritized the patients, and we were very consistent in our approach. We used something called the POMI tool. If we go on, I'm hoping that's next. Okay. So again, this is the model that we used. Yes, it advised us on this and helped us immensely as we were putting it together. But we had a series of letters, sort of 1, 2, and 3, and made sure that the patients would engage. We were very keen to make clear that this was not a "you're about to lose your painkillers" process. This was a "we are working to improve your health." And these patients did not see themselves as being addicts in any way, shape, or form. They would not necessarily have engaged with a treatment service. I call them accidental addicts, like people who become addicted to alcohol. They don't plan to do that, but it just sort of happens. And particularly because it's a legal substance and these are prescribed medications, there's a continuum. We talked a lot about patients who are addicted. What we found with this model is that we can stop that journey relatively early, simply by providing 1, outreach and identification and education, and 2, a structured, fairly straightforward set of psychosocial support. But we did have 19 people who ended up in OST. Could we just move on to the next slide? So this is the prescription patient opioid misuse indicator, very similar to DAST or the single questions. Positive answer to any 2 of these 7 questions indicate that the patient's at risk of misuse and requires further investigation. Since we started this, I've been doing a lot of training of GP practice really all over the country and just sharing what we've done. And some of the things that came out were patients who were seeking out locums, for example, who were less aware of their history of prescribing. Some who could be quite challenging in the conversations. But again, we found that most, if you had a structured approach, engaged very well. But things to look at in your own practice, you know, who's doctor shopping? Who never has a certain appointment with the same person twice? Are your systems in place to flag this up easily? Because if they're not, you may find somebody sneaking under the radar. And there are real risks with multiple prescribing. You know, people do die. There are investigations by the GMC, and it can have quite serious consequences. But of course, the person for whom the consequences are most serious is the patient. If we could move on. Just click through so we can show a few of these. So in the course of the structured service, we we had up to 6 sessions. We talked all about trust building, care planning, again, safe storage. Coming from a background of running an opioid service, long-term treatment, you know, safe storage of methadone is an absolute given. But often that wasn't so much addressed by patients who were having general prescriptions. It was put on a high shelf, but some of the sheer levels of drugs that were available were very high risk. We introduced the pain toolkit, we used videos, we talked again CBT for pain management and resilience and coping skills and relapse prevention. What happens if you do relapse? Do you feel comfortable about what you're going to do? So those were part of the overall service. If we could move on again. Just a couple of case studies. Some of the things we discovered anecdotally, a lot of people, because they were possibly frightened of the dentist or there weren't a lot of dentists available in North Lincolnshire, started by taking over-the-counter painkillers to deal with dental pain. When that got treated, they found they had a very interesting little sideline in addiction. So they would go back to their doctors with fairly interesting reasons why they needed more painkillers. And that would go on for a long period of time. We had a lot of patients we identified using the ORAT tool who had the injury for which they'd originally been prescribed painkillers was a thing of the past. We had one lady who broke her leg falling off a horse. And that was 4 or 5 years ago. She was still on an increasing dose of painkillers, and yet she had no apparent injury since. So those were things that were flagged up. And I mean, again, she was lovely. She was not somebody you were going to flag up as a problem patient, but that was actually what was happening. Another patient who was also a health professional, very concerned, but she knew what she was doing to a certain extent because the service was there, because we called her in for a review, and because she felt comfortable because she had up to 30 minutes for the initial chat, we were able to hold those conversations and enable her to go onto OST and then eventually become drugs free. Her mum came to one of the sessions and then said, didn't want to say anything, but I'm taking a huge amount of cocodamol. It is such a big problem. The Public Health England study showed quite clearly that, up to 1 in 4 people are prescribed potentially addictive medications. This is not a trivial issue. And it's not just the opioids that we looked at, there's gabapentinoids, there's a whole range of other drugs that can have these sort of impacts. So if we can move on, Helen. Oh yeah, so the chap who engaged with our system, by the way, saved so much money from his over-the-counter medication that he took his wife on a cruise. So there's lots of little stories that come out of this sort of thing. And one of our other patients who'd come back from university with a severe painkiller issue joined the service, and we got a lovely letter from his father saying that we'd saved his son's life. We talk a lot about this in terms of these are the technical bits and pieces, but it is the life stories that really matter. So what did we do? Well, we got 198 patients in. 10% of them ended up going into OST, which is a far higher number than I expected. 10 were very quickly drug-free discharges. Others had more complex treatment histories. A lot of patients stopped or changed their medication. We were able to follow up, and that seemed to be fairly consistent. Those were the people that struggled to separate mild withdrawal from a return of pain. Structured brief advice for that worked very well. And I can't stress enough how much forming a community which involved the health professionals, the pharmacists, the reception staff made the difference, because everybody was welcoming, everybody understood the level of fear some of these patients had about possibly losing their prescription. And one of the things we saw, if you look at the evidence from the States, when opioid prescribing became seen as a key problem, a lot of doctors just stopped prescribing. And a lot of patients had other sources of opioids, heroin, online, and it created a huge new issue. Anyway, what did we learn? Yeah.
You've got another 5 minutes, Graham.
That's absolutely perfect. Yeah, that's spot on. The first and probably most important thing was the patients who we thought would have a lot of difficult to engage with generally weren't. And if you're a health professional and you're thinking, I'm not sure whether I really want to raise this because I'm going to have a lot of trouble, I would strongly suggest that you just feel comfortable and ask the patients. When we were designing this project, my background was making every contact count, early interventions and alcohol, and we found that the early intervention approach worked very well. And a lot of people said, well, you won't be able to get anybody to speak about their problems. Often we found we couldn't get them to shut up once we started. So, we found the engagement was very positive and very good. Next clip, please. The level of ignorance about the potential of long-term opioid use was frightening, absolutely frightening. And as Yasser also mentioned, we had a lot of little old ladies who we describe as, who could be best classed as granny drug dealers, because they had a supply of painkillers, and if any of their family had a bit of a headache or something, they were quite happy to dish them out because they had far more than they needed. Now, how many young people then had a very interesting little buzz and got interested in drugs on the back of that? I don't know. There's very little research about it, but anecdotally, we saw quite a lot of this. Next slide. Again, families were concerned to the extent that, you know, even naloxone was offered because of so it could reverse an overdose. There is things we can do on the back of that to make it a much better approach for patients. They generally seem to not realise how out of it they were and how aware their families were of how out of it they were when they were taking these high levels of opioid painkillers. The brief advice model worked and worked very well. And yeah, the reception staff, I can't claim credit for this at all. It was the staff, it was the nurses who said, right, we need to know a bit more, and then became positively engaged, and we made it a very smooth journey from them. From the first identification of this patient looks like they could have a risk. And I say some patients are very, very resistant. Because we reached out, we had a split of about 50-50 between males and females who needed to enter treatment. And that is very unusual, because for people who work a lot on treatment services, it normally is about 70-30, mainly males, less females. And the final point I would make is that there is a huge hidden iceberg. You know, there is a big problem here. There's lots of polypharmacy. There's lots of socioeconomic issues going on. There's lots of mental health issues going on. And the best way to address it, we discovered from running the service, was to be very proactive, very positive, and support patients from that very first contact all the way through to either being assessed as being completely suitable for the treatment they're on, providing other support. You know, we're in an area where social prescribing is growing immensely. In many ways, these patients are ideal to transition into social prescribing, because that will give them the support they need to deal with their pain in other far more healthy ways. And my final point is, we learned a lot about this. If painkillers are being prescribed, the one thing I would say is it would be really nice if the patient knew what the end point of the journey was at the very beginning, because they need to fully understand the risks and where this could eventually lead. We're about to get things like cannabinoid painkillers coming on board, and that's non-addictive. But virtually everything that works is a bit addictive. You know, even chocolate bars and Magnum ice creams. You know, you have extra of those because they work. So we have to be very aware that there is a risk of addiction in so many areas around prescribed medication. Anyway, I hope everybody's enjoyed this. I'm quite happy to answer any questions, and I hopefully did on time.
Thanks, Graham. That's brilliant. And I've just brought us out of the slide share for a second. So, yeah, again, really, really interesting and useful stuff. I'm just going to look at the questions and see if we've got anything. Okay, so I've got one question that's come through, which is saying, what training did you give the reception and GPs? Was it the same training or different training? Oh, and actually somebody's saying they can't hear. So maybe speak up a bit, Graham.
Yeah, I'll just move a bit closer.
Go a bit closer, that's right. So yeah, the question was, what training did you give the reception staff?
It was very different. The training for the health professionals, depending on their sort of level of expertise, was often about the technical aspects of prescribing and more in depth around psychosocial behaviour and behavioural change mechanisms and models. For the reception staff, it was very much more about what to expect from the telephone call, how to be reassuring, what the key points to get across were, to the patient around what the review was going to entail. So it was a very different set of training. Often the GPs, there was, what alternative medication can be prescribed. Same with the pharmacists. One of the things we did with the pharmacists was say, we have this service. If you've got patients who are taking a lot of buying over the counter painkillers and also taking a lot of medication for stomach issues, that might be an indicator that you might have a little word with them, because obviously long-term opioid misuse and gastric problems can be closely associated. So the training was very much tailored for the type of way you are going to engage with the patient. So that's what we worked with. And again, in the early stages, it was driven by the feedback from the health professionals and the patients.
Okay, thanks, Graham. That's brilliant. I'm just having another look. There's another question that's come through. Somebody is saying they would be interested in more detail about this training, and can they email you? I mean, we'll come on to that shortly with Kieran. But yes, just to reiterate to everybody that's listening at the moment, yes, our contact details will of course be made available, additional information, and please do feel free to be in touch anytime. Now, any other questions for Graham at the moment? Okay, it looks like there's no further questions for you at the moment, Graham, but obviously the chat will remain open and we'll do a final wash-up session at the end. So in that case, I'll move us on to our next and final speaker, which is Kieran. So I'll just get the slides up again. Give me a second.
Thank you very much, Helen.
Thank you. Oh, I'm just trying to move it on.
Then move me on.
Suitably moved on. Thanks, Kieran.
Brilliant. Good afternoon, everybody. I hope you found the afternoon as interesting as I have. I'd like to introduce myself. I'm Kieran Johnson. I am the ReWire Business Development Lead, and some of you will have received emails from myself regarding today's session, but also some information about our skills and hands-on assessment service, which obviously is the purpose of today, is what we're launching. So what I'm going to do over the next couple of minutes is go through actually what is the skills and hands-on assessment service that we've launched alongside the full service provision, which Graham has mentioned. As Graham has mentioned, we have provided the full service provision for what we call switching off painkiller addiction. And what we also realised, and I think some of you have also picked up during the hour or so that we've been discussing today, is actually some practices, or some, for example, primary care networks, some other clients wish to have more of a training, some more training on actually some of the issues, rather than maybe having the full service provision within their own organisations. And similarly, also having some support around the hands-on assessments that we can provide with, just to help either identify patients or provide that psychosocial support as well. So that's why we decided that, as well as providing the full service provision, that we would actually develop alongside that our skills and hands-on assessment service. So this is a service which provides training and a practical support as well, or indeed a mixture of both, to our kind of clients, so that they can reduce painkiller addictions within their patient populations. If you'd like to move on, please, Helen. So just to briefly go through the skills development, this is our learning and development package. So this is where we're going to be delivering short training sessions delivered by painkiller addiction experts. So for example, Graham will provide training. We also have, as you can see, reducing the risk of litigation. We have some of our solicitor colleagues there who will be able to provide some training around those areas, as well as looking at working with pharmacists, working with GPs, and also communicating with patients as well. These are some of the key themes that we believe are quite important and quite prominent when looking at painkiller addiction. But of course, the services that we provide will be bespoke to your organisation and bespoke to actually what are the identified needs for yourselves. So if that's not on the list, and this list is not intended to be exhaustive, is that if there's anything, a specific area that you feel like you would like some support around, some learning and development around, we would be more than happy to deliver that. So just to thinking about our skills packages, appreciate that the current climate that we're in, and we are able to deliver these remotely via Zoom or Teams. Obviously, as and when things change, which hopefully I'm hoping won't be in the too far distances, we will be able to provide these face to face. But what we always say is that each of the sessions are completely interactive, and we can do that either online or in face to face. So none of the kind of learning and the training will be lost that way. Although we have various different topics for our skills and development sessions, these can be mixed and matched. So you may decide that actually only maybe 2 of the topic areas are actually relevant to yourself, or actually they can be standalone in their content too. It's entirely dependent on what you require. As I mentioned before, we can tailor to meet the topics which are prevalent within your area or within your organisation. And because we appreciate that time is of essence as well, our sessions are bite-sized sessions in the first instance. So we will provide 2 hours in length of our learning and development sessions. And if there is a need for that to be longer or to have a second session, then of course we will do that too. As well as having our kind of learning and development sort of arm towards with the ReWire service, we also feel, and we've also had feedback from practices and from primary care networks, that actually they would like some practical support in helping deliver some sort of painkiller addiction support. So this is where our hands-on assessment service comes in. So this is the practical support for every stage of the process of reducing painkiller addiction. So, for example, Graham's mentioned a lot about how he and the team have identified patients at risk of painkiller addiction. So they've been able to identify those early, how they've been able to engage with patients, also provide the kind of psychosocial support around and using some of these techniques in developing resilience and relapse prevention. So we can provide the actual hands-on assessment as well and provide that handhold to the practices of yeah.
Oh, sorry, was that you?
Brilliant. Well, I'll carry on.
Yeah, no, that's great, Karen.
So as well as doing our hands-on kind of providing that reassurance or helping set up an identification process using some of the tools that Graham has mentioned, we also appreciate that one size doesn't always fit all. So we've also developed different packages of support, which is a hybrid of some learning and development, but also some of the kind of hand-holding as well. So of course, this is to meet the needs of whatever you require should you need that. And sometimes, like I said, we know that some of these packages may not suit what you require at this stage. So, you know, please do let us know and we can build something up that will meet the requirements of your organisation. So these are some of the kind of ideas that we have around packages. And also one of the kind of added values that we have is that we'll be able to provide online support to access via our ReWire forum. So you have other peers who are working within this arena where you'll be able to maybe look at best practice, chat about any issues that you have, as well as looking at some of the kind of live webinars that we can provide and some of the hands-on assessment modules as well. However, we also fully appreciate that, you know, some practices or some primary care networks or some other clients may want the full service provision, so may want the service which Graham described as well. And if you just won't mind moving on, please, Helen. So we can also provide the full ReWire service for you as well, which this slide just shows really what the stages that we do, which Graham has already spoken about at great length as well. So kind of to summarise is that the purpose of today's webinar was obviously to hear from Dr. Abbasi, from Graham about, you know, what has happened, what is happening nationally, what we have done as a ReWire service, as an innovative service providing reducing painkiller addiction nationally, but also to launch our skills and hands-on assessment service, so providing like another tier of support that we can provide to your organisations. Does anybody have any questions, either for me or for, sorry Helen, I'm going to chair it, but for everybody else as well?
I could say thank you very much, Kieran, and well, we have come out of the slide share now, so hopefully you can see us and hear us nicely. I think we've got one question that's come through.
Can we review the teaching session at a later date? Can my colleagues see this? Yeah, so what we will be sending out the skills and assessment package, I believe, at the end of this webinar, which will have all the additional information in there, which I've briefly touched upon. If you would like to have further discussions, please do feel free to get in touch with myself, or of course anybody within the ReWire team, where we'll be able to discuss a bit further the different options that we can maybe support you with.
Thanks, Kieran, that's brilliant. Any other questions for any of us? Obviously, we're here and very happy to help in any way we can. If there's anything you've not had chance to ask, or any other comments, or then please speak up. Okay, well, we'll just wait around for another couple of minutes, so please do send through questions if you've got them. Otherwise, thank you ever so much for attending. As we said, we really do hope that this has proved useful to you and interesting, and please do feel very free to follow up with any of us as you might wish to do so, or share with colleagues as appropriate. But otherwise, we'll just hang on for another minute or two, and yeah, please do speak up if you want to.
Can you hear me, Helen?
Yes, we can all hear you, Yasia.
Oh, good,
and we're
good.
still recording, so...
We're still recording. Brilliant. So just a question for Graham, really, a comment and question, really. It was brilliant work that he's highlighted, how he went and evaluated almost 8,000 patients. I'm trying to figure out whether these 8,000 patients were within one surgery or was it a couple of surgeries. And what were the response of the clinicians at the surgery when you highlighted 8,000 patients out of their caseload. How did they feel about it? Were they surprised, or were they expecting this?
In answer to your question, it was across several surgeries for a start. And also, when we first started, we actually we reduced the level of assessment because we were highlighting so many cases. If you went into the older age groups, it became close to unmanageable, the level of prescribing. The clinicians we were fortunate. We had a couple of clinicians very much on board who acted as the role models and champions. And then as we demonstrated the fact that this worked quite effectively, the other clinicians came on board, and we got some lovely telephone calls saying, just, this has happened with this patient, can you help? So it became a very mutual, beneficial service. The other thing about the 8,000 was 8,000 were assessed by the software. Obviously far less than that were actually called in for interventions, etc., because otherwise we would have been very busy indeed. But yeah, it was surprising. And I think the other thing that came out was that a lot of our live results matched very closely with the previous studies that had been done. It surprised me how, that sort of 20 to 40 patients per thousand at risk, all those elements emerged. But in terms of clinician resistance, no, we had more requests for training and more requests to be involved than we expected.
That's brilliant. Just another follow-up question to that is you kind of mentioned about 10% were on opiate substitute treatment. Interesting, very interesting. But anything in particular which was common in those? Did they have more comorbidities, or were they on very, very high doses, or were they very resistant stops? Or were there any common string amongst those 10% who ended up on OST?
Less than you would expect. Yes, they were quite high. They were obviously on the high doses. Very wide demographic breakdown by gender was very wide. What we found was that half of them were very easy. We went into OST and they came at, they basically went through a withdrawal process and a structured treatment, and they were very quickly out of treatment. We found for other patients, they had lots of psychological comorbidities, some of which often hadn't been identified fully, and they were more complex to treat. So there was I wouldn't say there was a clear pattern, Yasir, but yeah, they went into treatment fairly positively. We had to do things like manage the way they got their methadone so that they weren't around other patients, because obviously they were completely treatment naive. So we had to work close with the pharmacies to make sure that when they were on OST, they were, let's say, safe from other influences when they're going to pick up their prescriptions, etc.
Okay, thanks very much, Graham. And Yasir, we are out of time. I just had one nice comment come through on the chat to say thank you very much. It's been extremely interesting. So thank you for the feedback. Always nice to have positive feedback, so thank you. But that, as I say, means that we're out of time, and thanks again to everybody that's been able to join us this afternoon, and thanks of course to all of our speakers, and we will be in touch, as I say, with a follow-up email with various extra bits of information, so please do stay in touch as you wish. Have a good afternoon, and thanks very much, everyone.
Thanks, everyone.
Bye.
Bye.
Thank you. Bye.
Bye.